If you want to be a dope internal medicine resident, then you need to know a little something about dialysis in the hospital. But there's a dirty secret you may not know. If you haven't done a nephrology rotation, trust me, the kidney doctors are intentionally keeping you in the dark about this one. So in this video, I'm going to expose the secret, explain how it affects your day-to-day patient care, and propose a concrete tactic to directly combat it. By the way, I'm sea bass. Yes, like the fish. I'm an Ivy League nephrology attending and medical education nerd bomber. Pro tip, if you haven't already, click 1.5x and you can learn something with me in less than 10 minutes. Okay, on to the dark side of dialysis. Here we go. Let's say you call your friendly neighborhood nephrologist and tell them, we just admitted this patient. She usually gets dialysis Monday, Wednesday, Friday, so she's gonna need some dialysis while she's in the hospital. Let's break down your call. Technically, it's concise. The shared ownership of the patient is clear. If the patient needs dialysis, then you've engaged the team who is responsible for the doing of the dialysis, which is good. By the way, if you get pushback for that consultation, do not let the nephrology fellow gaslight you. Patients who need dialysis in the outpatient setting also need dialysis in the inpatient setting. Duh. But frankly, your initial consult call is ortho bro quality. It's bare bones. And let me tell you what's going to happen if you go bare bones. You're going to let your consultant off the hook and give them a reason to deliver subpar care to your patient with end-stage kidney disease. Here's why. At many institutions, nephrology exists as a consultative service in which they are not the primary caretakers of the patient. A corollary is that there's no ceiling to how many patients the nephrology consult service can be responsible for. This means that the kidney consult list can balloon up to comically high numbers. I remember one time in the spring of my first year of fellowship at the University of Pennsylvania, I walked in to look at the nephrology list and found that there was 35 patients there. 3, 5, as in one less than 3 dozen. So let's call this problem Problem X, the problem of too many patients. I stole these blocks from my toddler. Each color on the x-axis represents a different patient on my list. But that's only half the story. Anybody who's ever worked at a quaternary center knows that the number of patients doesn't say anything about their complexity. The flip of this would be if your list is a rock garden, right? A collection of patients awaiting disposition does not require a lot of supratentorial effort. Okay, so let's call that problem Y, the problem of complexity. On the y-axis, the height of the blocks represents how complicated a patient might be. Then we plot these out on a grid to make a histogram, where the total number of blocks represented is how much intellectual work the kidney consultant has on their list at any given time. Okay, so we're halfway through the video and you might be saying, what's the dirty secret, Seabass? Nephrology is complaining about how much they have to think. So let's say that this is your dialysis patient that we talked about at the beginning of the video. 5 blocks in height means that they are medically complex. The dirty secret is that the quickest way for the nephrologist to cut corners is to not think about the patients with end-stage kidney disease. If the patient requires dialysis on a regular or routine basis, the nephrologist can mindlessly plug and chug a dialysis prescription and turn a 5-block patient into a single block. Now, in the world of internal medicine, this is heresy. After all, we place a premium on thinking. All the Reddit threads roast us for spending multiple hours on rounds waxing poetic about minutia and esoterica. So then, how can this be? Well, I can write a dialysis prescription that addresses the bare bone needs of the patient, making sure that they get decent clearance of uremic toxins and decent ultrafiltration to remove extra volume. This means that on a busy day, when I'm consulted on patients with end-stage kidney disease, I can go full frontal ortho bro. The patient has a fistula. Let's dialyze it. And by doing this, it frees up my brain space to take care of patients in the hospital whose acuity demands more of my time and attention. The severe hyponatremia patient who needs careful titration of hypertonic saline, the acute glomerulonephritis that I am thinking I may need to immunosuppress, the metastatic cancer patient with severe oligoanuric AKI that I need to have a serious conversation with their family. Okay, so the dirty secret is that I may not be thinking much or at all about your patient with end-stage kidney disease. But what about your patient? When you originally called me, you told me that her dialysis schedule was Monday, Wednesday, Friday, and that's helpful. But maybe what you didn't tell me was that the emergency department billed her as quote-unquote pneumonia, and now she has a new oxygen requirement, but the consolidation on the plain film looks weak sauce. So really what you're dealing with is a patient who has undifferentiated sepsis and undifferentiated acute hypoxic respiratory failure. This raises a lot of questions. For example, does she have pulmonary edema? What's her typical target weight? Is she bacteremic? Could her dialysis access be implicated? And oh, by the way, her hemoglobin here is 8, but we don't have any labs in our system for like the past year. Is her degree of anemia acute or chronic? It turns out that you might actually want me to think about your patient. And if I were to spend a little extra time as a nephrology liaison, I could dig up the answers to most of those questions by closing the loop with the patient's outpatient dialysis unit. So how do you navigate this? How do you encourage a consultant to not be lazy? Take 2 with a touch of diplomacy. How do you encourage a consultant to do more work? The answer is a second secret, but this secret is more so like a not so secret. Kind of like the secret menu at In-N-Out Burger. It may not be listed, but a bunch of people know about animal sauce. I want to empower you with a full menu of outpatient dialysis medical problems for which the kidney doctor is responsible. That way, when you have a general idea of the full menu, you can gently prod your consultant to do some more digging on your behalf. But first, 2 quick things. In this next video section, when we refer to the unit, we're talking about the patient's outpatient dialysis center, not the intensive care unit. And in a completely stable patient on dialysis, a full set of labs may be only drawn like once a month. Okay, and with that, let's hop into the full menu. Hypertension and hypervolemia. In the outpatient dialysis unit, several metrics are systematically taken at each dialysis session. This includes pre-dialysis standing weight, post-dialysis standing weight, intradialytic weight gain, and serial BP measurements before, during, and after each individual dialysis session. To a kidney doctor, hypertension and hypervolemia are inextricably linked. So much so that in the dialysis electronic health record, these data are located in the same subheading. If a patient with ESKD is persistently hypertensive, then the top 3 things on the differential are volume, volume, and volume. Adequacy. The question here, is the dose of dialysis appropriate? This concept is addressed with fancy math equations that can model urea kinetics from labs drawn in the unit. This in turn spits out a number, and this number gives us an idea of whether the dialysis prescription is sufficiently cleaning the patient's blood. Access. The machine measures arterial and venous blood flows. These numbers give us clues as to whether we have enough flow to match the prescription that we've written, and also gives us clues as to potential stenosed or clotted access. Anemia. Units typically use protocols to dose both erythropoiesis-stimulating agents as well as intravenous iron. Usually the goal is to keep a patient's hemoglobin within a target range, something like around 9 to 11. Nutrition. Dialysis routinely measure most electrolytes, potassium obviously being the one that's given a lot of attention. They also have the ability to deliver intradialytic parenteral nutrition to those patients who are severely malnourished. Mineral bone disease. Units use protocols to dose both oral and intravenous agents meant to keep the IPTH within an acceptable range. We also serially monitor the phosphorus and the calcium. Infection. Centers usually have the most common intravenous antibiotics on site and often have the logistical capability to have less common antimicrobial agents delivered if given advance notice. This can spare the patient a small bore catheter placement. Transplant. Transplant nephrology is a portal into an entirely separate world. We're talking Stranger Things level upside down swag. The transplant team usually gives our patients a lot of homework because if they're potential transplant recipients, then a lot of specialists need to give their stamp of approval. Get a cardiac stress test, get a colonoscopy, make sure your hemoglobin A1C is within a very particular range, etc., etc., etc. The outpatient dialysis team's main role in all of this is to make sure the patient's being held accountable to check these boxes. Medication reconciliation. Many meds need to be dosed for end-stage kidney disease, And some meds are dialysable, which means that the timing of administration needs to be carefully considered. Most nephrologists could put you to sleep with an entire hour-long lecture about each of those outpatient dialysis topics that we just hit rapid fire. The main goal here is to make sure that you're aware of all of them. Again, just having an awareness of the secret menu means that you're going to be empowered. It will allow you to gently nudge your kidney consultant into thinking a little bit more deeply about any one topic area if it happens to meaningfully interact with the other inpatient problems that you're trying to address. That's it. If you got something out of this video, smash the like button, click subscribe, and if you want to have more meaningful interactions with your consultants, say you're a new intern and it's July or August, or maybe you're a new second year who's been put in charge of a new intern, check out this video right here.